move on. I don't know if we are in the critical care meeting or whether we are in oncology, hematology, uh, genetics sort of a I think that's the way things are going to be. The next is the first ProCon session of Reflect 2021, and it's on target map 65 in SHOP. Uh, Dr. Pradeep Rangappa sir is going to speak uh, pro, and Dr. Arindam Kar sir is going to speak against. So, Dr. Pradeep Rangappa's videos are with me, so I'll play the pro video first. For this session, I request Dr. Ghanshyam sir to kindly moderate the session.
Thank you, Dr. Madhulakshmi. In intensive we have always been kind of fascinated by numbers, trying to give numbers to each and every intervention we do. And to debate whether 65 is a good number in patients with in septic shock. Uh, Two very good speakers, very dynamic speakers, and both of who can think out of the box. Start with Pradeep speaking in favor of 65 as a number to target in septic shock.
For a debate targeting MAP of 65 in shock patients. So as you would all be aware, that 65 is kept as a arbitrary figure for resuscitation in any type of the shock. So the pro-debate agenda that I would be covering is a bit of a background on this MAP of 65 and evidence that is available so far for MAP of 65. So I will talk about 6 studies. So there are 4 studies which argue for favorable outcomes with MAP of 65, and there are 2 studies which look at how having a lower MAP also may not be desirable. So one is I looked into 4 studies which have compared higher MAP and MAP of 65, and there are 2 studies which look at how lower MAP may not be very desirable, concluding remarks and the rebuttals. So when you look at the mean arterial pressure, so if we have a target of lower mean arterial pressure, what that implies is the perfusion pressure will be low and the CVP would be high. So this is the sort of a correlation that one would have. If we target a map of higher target, then perfusion pressure would be high and CVP would be low. So this is a sort of a rough correlation that exists between the perfusion pressure and map and the CVP. So we looked into the evidence. So that, as you know, the surviving sepsis guidelines recommends a map of 65 in patients with septic shock requiring vasopressors. So this particular study came in 2000 from the US group, where they compared 2 groups, map of 65 and map of 75 to 85. So they compared the 65 target mapicam RPA with higher map. As you see in this, the cardiac index 55 map was a little low as compared to this. But when you look at the clinical endpoint, which is the urine output, lactate, oxygen delivery, and oxygen consumption, there was no difference between map of 55 and higher map. So, if you're not convinced with that study, then there was this other study which came from the French group in 2005. Again, they compared MAP of 65 and 85, and here again they showed cardiac index was a little low when you target a lower MAP, 4.8 versus 5.8. But again, for us, what is most relevant is not the numbers, but the outcome variables. They looked at renal function tests, lactates, which is an indicator of tissue perfusion, and oxygen consumption. Again, there was no difference between lower MAP and higher MAP. Then this was a landmark study called the SIPSI-PAM study, came in around 2014 again by the French group, and this is sort of largely cited by Puritans who would argue that one map would not fit everyone. But again, if you see here, they compared 65 to 85, higher map to lower map. Let's look at mortality. So again, this study, in fact, it favors my argument that 28-day mortality was not high in map of 65. So it was not inferior. So there was no difference between 65 and 85. So we could afford to maintain a lower map. And 90-day mortality also there was no difference between 65 to 85. On the contrary, what you see, the arrhythmias were higher with a higher map. So the Puritans would argue that higher map was beneficial in certain subgroup of patients, patients who have had chronic hypertension, where the risk of RRT was low. So this was the only positive endpoint that it showed to be beneficial in higher MAP and specifically in a group who were premorbidly having hypertension. So otherwise, there is not much difference between 65 to 85, and in fact, the complication of arrhythmias was more in 85. Again, so this would favor my argument that 65 should be good enough. It's always good to have some number in mind to act upon rather than being very nebulous about what sort of targets one would have in mind. So then if we are not convinced with these three studies, then this was one study which possibly makes things little confusing. It came from Canadian group. And this is the most recent 2016 study, 118 patients. They took elderly patients, more than 75 years, and they compared MAP of 60 to 65 and 75 to 80. You see, the mortality was significantly less in patients where the target MAP was maintained at around 65 or 60 to 65 as compared to higher MAP. So these are the 4 studies which has compared target of 65 to higher MAP, and all these 4 studies reasonably conclusively endorse the point that we don't need to really target higher MAP for achieving any clinical benefit. And if you have to subscribe to this Canadian study, it tends to favor a little lower MAP in elderly patients where it showed mortality benefit. So these are the 4 studies where one could subscribe that 60 to 65 is reasonable. Now my opponent, okay, I don't need 65 MAP for anyone, I would want to target lower MAP with a big term, less is more. So that's how this word, less is more. So he may argue that I want lesser than 65, why 65? So I will show 2 studies which argue against why lower MAP also may not be desirable. So this is the most recent study. In fact, this study is not published, but there is a good editorial that's come on a preprint sort of a study. This is a very, very exhaustive study by Darshenko et al. April 2020, there is a preprint manuscript available. And for this, there is an editorial which is coming in AJRCC in April 2020 by James Russell. So personalized blood pressure targets show what if your blood pressure is low. So in this particular study, very interestingly, they have shown how having a lower MAP may not be very desirable. But this is a very exhaustive study where complex analytical sort of statistical tools are used. But I won't go into too much detail, I'll just give you an essence of what this shows. So basically in this study, they said the pre-morbid systolic arterial pressure is inversely proportional to the patients needing the vasopressor dose and the duration of vasopressor. So it means to say, if your pre-morbid systolic arterial pressure is low, then they would need higher vasopressor, and the need and the duration of them needing vasopressors also would be longer in case they become sick and become hypertensive. That's what was the hypothesis, and that's what they looked at. So here it was a very big study, 4,689 patients done between 2012 to 2018. So here if you see, they divided into 3 groups. So the first group was where pre-morbid systolic arterial pressure was less than 100. It was systolic arterial pressure, which is coincided with lesser MAP. And then the second group had a normal blood pressure, which is systolic of 100, and higher blood pressure where they had more than 140. Here they looked at patients with a MAP needing vasopressors. They found that patients who needed vasopressors, the MAP was always found to be lower as compared to the normal. It means to say, in the same vasopressors, the MAP that could be achieved was lower. In patients who had premorbid blood pressure, it was lower. And again, they found that vasopressor need was higher in the patients premorbidly who had a lower MAP. So this goes on to show that patients having low MAP, suppose my opponent would say, this patient had always had a low MAP, I don't need a MAP of 55, which means they needed higher vasopressors and they needed vasopressors for a longer time, and possibly they had more organ dysfunction, although it was subgroup analysis, they did find that organ dysfunction also was higher there. Which means to say that this is not something which would be desirable. As you see in the subgroup, they found in the premorbid patients where patients had a lower MAP and you use vasopressors, and if my opponent subscribes to lesser MAP is good enough, they had high mortality and they had increased ICU length of stay in this group of patients. And but there was no increase in the need for RRT and organism. So this very exhaustive study very clearly indicates that less is more does not apply for blood pressure in this group, because premorbidly where they maintain lower MAP, with vasopressors you tend to target a little lower MAP, they had a higher number is possibly 65 and more, because less than 65 is not found to be safe, at least in this particular study. And the study also re-emphasizes that when we look at MAP, we are all clinicians here, we don't look at only the number. Along with MAP, this editorial and these authors re-emphasize that we need to look most importantly at the peripheral perfusion, because the normal peripheral perfusion less than 2 seconds is normal, more than 4 seconds is abnormal, and if it is more than 5 seconds, it may have a good correlation with worsening organ function. So it is imperative that we don't look only at MAP. Along with it, we need to look at the end organ function. Peripheral perfusion is a good sign, and again we need to look at the urine output, we need to look at the medication, and we need to look at this lactate in concurrence with the MAP. I think that is the take-home message in this article, that we don't look only at MAP. Along with MAP, we need to integrate these clinical indicators to ascertain that we are achieving good tissue perfusion. So that was the essence of this study. And after this is a very important study which came in JAMA. Again, it goes on to show maintaining a lower MAP may not be desirable, less is more does not apply to this. So if you look at the title, the effect of utilized was the standard blood pressure as a post-operative organ dysfunction amongst high-risk patients undergoing major surgeries. So the randomized controlled trial. So one would say, okay, I am targeting for the targeted pressure. It is not targeted. Here they did not allow patients to develop hypotension of lower MAP. So aim was to look at the high-risk patients undergoing surgery and then look at individual systolic blood pressure versus standard. Standard is where they allowed patients to have hypotension only after certain degree of hypotension they acted. So looking at these patients whether they have organ dysfunction, because the multi-centric stratified parallel group RCT, sample size they had 268 patients. To achieve 90% of power, they had to look at absolute difference of 20% in primary outcome. So 9 hospitals, December 12 to August 2016. Inclusion criteria was age more than 50 years and patients who underwent surgery under general anesthesia. The surgery should have lasted for 2 hours because they took only 6 patients undergoing major surgery. And ASA had to be more than or equal to 2, and all these patients were at a high risk of developing EKI. So 298 randomized, 149 in intervention, 149 in control group. So the percentage receiving abdominal surgery, 84% of them had elective surgery. So intervention group. So here, as you see, they made sure that the systolic blood pressure did not drop to less than 10% of reference value, and they used norepinephrine to make sure that hypotensive episodes did not happen. Again, the study emphasizes that less is more does not apply. And control group, they allowed the blood pressure to come down to less than 80 and less than 40% of reference value, after which they used ephedrine to or ephedrine or norepinephrine as a rescue therapy. So results, the primary outcome, they looked at composite of SIRS with more than or equal to 1 organ dysfunction. So if you look at that, they had 147 patients where they did not allow hypotension. They only allowed a margin of less than 10% of systolic blood pressure, and that here you see the composite, the primary outcome, which is a composite of SIRS with more than or equal to 1 organ dysfunction, was significantly less. It was statistically significant at 8.1 as compared to 51.7% with absolute risk reduction of 14. The number needed to treat was 8. And they looked at renal dysfunction significantly less in the group where hypotension was not allowed as compared to the other group where possibly my opponent would do less is more and allow them to become hypotense. And that was also statistically significant. And altered sensorium of delirium or post-operative organ dysfunction was significantly less at 5.4 versus 15.9%. So this is again the table showing the results. So the conclusions they made was treatment targeting individualized system. Here individualized systolic blood pressure is not customizing the patient's state, making sure that the patient does not develop hypotension, reduce the risk of post-operative dysfunction as compared to the standard therapy. So that would be my sort of a side of the study. So I will allow my opponent to talk about this side, and then I will talk about the impediment.
But this is online or what?
You have the advantage. In them you have the advantage.
Yeah, Ganesha watching our ranks for I'm pleased to come again, I think, and like that, I always try to do this. Pradeep has done a good job. He has done all the studies, put all the good graphics. I think we can skip because we have already a lot of presentations from all this stuff. And anyway, my presentation was very shortly made. I didn't get time, honestly. But I do have time to read all this through. And also Pradeep made my job much easier presenting it in front of us. I do not have any financial disclaimer. I think this is a little bit of fashion to say that I do not have. Whatever I have given into the ITR. The rest of you should not know that regarding this. And this is more of a, I think we should little chill out throughout the day. We are doing all this stuff. And I think academics is one of the sort of our good excuse to meet up. And when we have met up for almost after 2 years. Mohanji, last year we didn't meet, right? So last year we skipped the reflect because I think Srinivas made it online. So it's good to be back. So thanks for that part also. Before going point to point on the 6 studies that he came up with, right, I might take that's another advantage that I might take a little more time to analyze. First, let's see what is evidence-based medicine, because emerging evidence in critical care, EPM, right? So, because there are different definitions of EPM. In fact, some says that, for example, a good speaker like Pradeep or Ramsan is there, or Dr. Pandit is there. The EPM can be called as eloquence-based medicine. That means a speaker who speaks well will mesmerize you, and then you go back home taking his message. It may not be corrected then. Then sometimes it could be evidence-based, someone who is very good in a good name, big name, and all that. So life or our practice is mixture of everything: experience, eloquence, evidence, but most importantly, the common sense, which we should always have, and the physiology. That's the most important part. And in terms of the pro-con debate, I'm not the con man. I'm just speaking against that part. So let's see what is the concept of mean arterial pressure, which Pradeep showed very nicely. That the higher mean arterial pressure gives you a better perfusion and a lower CV. We all know that. In fact, one of the concepts that is more being put forward, that it is the mean perfusion pressure is more important than the mean arterial pressure, and it could be variable in different organs, right? Because for example, in renal perfusion pressure, the intramedullary pressure has to be subtracted from the mean arterial pressure. In brain, it is your intracellular pressure. So you have differential perfusion pressure in different organs. So think of, you have a differential perfusion pressure which is useful in different patients. So how can one target would be individualized to every single individual patient, right? So here, the Pradeep has already taken this point that we have to have 65 is something that we look up to, but it cannot be sacrosanct. Something is good that this is in and around, we should be there. But I think for every individual patient or even every individual organ, we have to have a specific, or what we call is good to say precision, individualized, precision-based target itself. And why the 65 came, as Pradeep showed, the first 2 trials, right? The first 2 trials of Ledox in 2000 and the Bourgoin in 2005, both which compared 65 versus 85, he has very clearly shown, Gansha, we have seen that also. No mortality difference, right? Absolutely no mortality difference, and also nothing difference in your oxygen consumption, oxygen distribution, your urine output and others. But still, as we were discussing, Srinivas very clearly told, if you have gone through, I have been fortunate enough in one of the guideline meeting and all others, it's all about, all decisions are very, very arbitrary. So you can have a very strong evidence, but eventually it depends on that how the guideline honchos think that what should go to the common people at the end of when the guidelines is published. For example, Dr. Pandit will agree with me. What happened in Zyglis? There were 21 people. The voting happened. If you remember the story, it's published in the. You can go and see. 15 of the people said that we don't know. 5 people said against, and 1 refrained from voting itself. Right, and still it was published with a strong evidence. Am I right? Would you support on that point? So that's how the guidelines are made. Right. So even the best on 2 studies which showed no difference between 65 or an 85 itself was included in the guidelines. It is still included in the guidelines. Is it still there? 65 with a strong recommendation and others. So this is the fallacy of the evidences, and we call about evidence. I'm sorry to say, my friends, the evidence that we say, which is so sacrosanct, which is so sacred, that we come every year to different places and then change the evidence. Right. So that's the validity of an evidence itself. Anyway, the other part is that, as I told, that Pradeep was very correct on that it is not only a map, but it is about our clinics. That we see the perfusion pressure, we see the skin colors, the turgor, the global markers like your lactate or any other markers, and the poor man's CBP or poor man's BP, the urine out. Right? It's a amalgamation of everything, right? Your clinical senses, your intuitions, your perception, that gives that what should be a mean arterial pressure for an individual patient. So now what is being after this, let me come back to Pradeep's other 2 trials. The biggest one was the ASPER, which was published in NEJM in 2014, right, which showed a mortality difference. And how much was the mortality difference? 1.6, right. So I have a friend, Peter. He's in Czech Republic. He's an official statistician, statistical analyst expert in ESICM. He's an intensivist as well as statistical expert in ESICM. You give him any study, and he can apply different statistical methods and give you 5 different results. Right? And we always take these benefits and others according to the based on the statistical things, and we don't understand any statistics. So we just read the part that this is statistically significant, and then we try to apply this thing in our practice itself. So that's how we are actually going. Right. So, and 1.6 of statistical difference was the very Pradeep was jumping on his seat about that this is the 65 is the best thing as ASPER told. Regarding the Canadian trial, right? If you have time, please go through that. I just read it in this book itself, and I stopped after 2 minutes because it's ridiculous just to have a 65 versus 85 mean arterial pressure. The mortality difference is 13 versus 60. Right. So, do you believe this one? This has happened only because of the mean arterial pressure. 13 versus 60. That was the mortality benefit that they tried to show. So that's why no one read that trial. Even I stopped after 1 minute. Even I had a compulsion to read that. So, but this one, James Russell, who is doing a work for years, almost 2 decades now on it. Unfortunately, I know him in person also, right? What they have come up with is an idea for the pre-morbid blood pressure. That means, what is my blood pressure, right? What is your blood pressure? Whether you are an hypertensive to start with, and I can pretty well say a lot of women in India do have a lower blood pressure, right? If you say they are 90 by 60 is a normal or 100 by 60 is a normal. So what they tried to find out, this trial, is that whether the pre-morbid blood pressure is inherently bad for the patients to have, or whether just to increase their blood pressure, we are giving more vasopressors and that is causing more harm. That means you have started with a lower blood pressure. So everyone is saying, okay, let's spike up to our mean arterial pressure to 65. So you give more fluid, more vasopressors, and eventually it is causing more harm. So what they do, Pradeep is a very sharp guy with the intelligent questions of 180. He didn't tell that. They looked into the people who had a pre-morbid SAP, and they found they were much younger, but more sicker and more cardiac dysfunction. Because think of a younger patient with a lower blood pressure, why would they come with a quick back shock in an ICU itself, right? So they were inherently sicker patients, and that's why the idea of hiking of the blood pressure with higher vasopressors was it. And very clearly they said that we couldn't understand that what was wrong. Whether it's a premorbid systolic arterial pressure lower, that is the reason of having a bad outcome, or giving more vasopressors to hike up the mean arterial pressure to achieve the target was more wrong. So they ended up with an open situation, open question that maybe bigger trial will be required on that. And the last one, the JAMA trial, the foot-year in 2017, right? If you have read this trial, is ethically, do you think it is ethically correct that in your non-intervention group you are waiting for things to drop down to a day? Don't you try to improve the situation before it goes out of your hand, right? Don't be preempt everywhere. Don't be target that if my hypertensive patient coming from within a surgical ICU with a big BP drop, I try to achieve a little better mean arterial pressure rather than 65. So what sensibility was playing where you are actually in an intervention group, you are putting your mean arterial pressure within 10%, you are acting preemptively, and in the other group, just to make your intervention group look so good that you are not acting on it. So I think Pradeep, in a rebuttal, if it is a recorded rebuttal, he won't be able to answer, right? Or maybe later on that part. So I would be finishing off in a good note that the personalized or individual care may be combined with our clinical senses, and in future direction maybe an organ-based target could also come, but still then I think good clinical senses, perception, intuition will be guiding us for an individual care for each individual patient. So that would be an aim. And also to keep in mind that not only the macro circulation, there are a lot of things that happen in the micro circulation which has also to be considered in shock itself. Till then, pragmatism, prudency should guide our clinical judgment itself. And target 65 gives us a perspective. It doesn't give us a target itself. We should work around it, but we should not be completely clouded by the 65 number. We should be taking individual decisions for it. Before I end, rebuttal, I don't know what Pradeep is going to say on that part, the recording part. I will try to counter that part. I officially invite you, also our President, ISCC President, Dr. Deepak Govind would be coming. There are all ISCC, Dr. Maharaj himself is the executive committee member, Ghanshyam is the Vice President. So we all together invite you to the conference which is happening from 16th to 20th February in an amazing convention center of Gandhinagar, Ahmedabad. So please do join, and also officially as the Hyderabad, Vizag and other chapter office bearers are present, there is a opportunity of huge discount if you are doing a bulk registration sort of thing. So please do connect with me post program. The discount is according to it's a slab wise. It goes up to almost 40% discount according to the numbers. So, but we have two. It's an what would I say? According to the numbers also. For example, Vizag is a smaller area. We have 100. Hyderabad is a metro sort of thing. So if more than 100 people do together, if Ghanshyam arranges that, so there is an almost 30-40% discount. For you, the numbers comes down, right? So that's how we are doing. Okay. So please, we will connect. So thank you, and let's hear Pradeep what he is saying.
Yeah, these pages, please keep in mind.
So thanks Arilal for his presentation. So the rebuttal from my end. So the question is, why do I follow a target map of 65? So when targeting having one number as a target, so I would have some element of homogeneity of care and makes my actions more predictable. So if I do not have any number, then it's very hard for us to determine what sort of a number we should be looking at. So there should be some reference point that would at least ensure there is homogenization of the care. And whatever action we take, either increasing or decreasing, would become more predictable. And it would possibly ensure high quality of action by our entire team, because it's impossible to get our understanding percolate to everyone at the nursing level or at the other junior doctors level. So it is imperative that we have some number to work with and then act upon it or build upon it in the way I want to convey. And most important thing is it also help us in minimizing the potential harm, because if you do not have any number, then one may come and say, okay, he has a map of 50, so everything was fine, he was taken during. But on the contrary, then you may have realized that there will be other organ dysfunction or something sinister may have happened. So it is important that maybe at a very senior level you could possibly work on individualizing the map, but for ensuring some standard of care, one needs to have a number in place which people could work on it as a reference. So that is very important. And by not following a target of one number, it may result in a lot of confusion, lot of ambiguity in the team, lot of anxiety, apprehension, and a lot of conflicts and confusions can arise. And the consequences, because in your pursuit to have your own understanding of less is no more, less is more, and targeting lower map or very high map, could possibly lead to unpredictable outcomes, which can lead to a lot of legal ramifications. And it could possibly leave a lot of your team members confused, being not very clear as to what your thought process is for each patient. So that becomes very divergent to the whole standard of care that one would want to be looking at achieving. So that is where the whole problem is. In fact, this is a good cartoon which really looks at how comparing as to not following certain guidelines would tantamount to being in hell as compared to following guidelines at least you are in a sort of heaven with this. So this is a cartoon which I took where it again re-emphasizes how important it is to have some number and work towards that number. So I would go down to having certain numbers, and always in ICU we do have to work keeping some numbers as reference and working around it. And having this as a checklist and homogenizing the care with all doctors aligning to it will ensure certain standard of care, as opposed to someone who is trying to individualize for every patient, it would only create a lot of chaos. And I would urge every listener to read this book, the Checklist Manifesto, which clearly emphasizes on the fact that you need to have checklists in ICU or for the purpose in healthcare. To attain certain standards of care, you need to have certain goals set in your practice, and you need to use this. I would urge every reader to read this. So if you are trying to individualize care to every patient, it means that you need to have many heads like this. So you have to be a god literally to try and say, okay, I'm going to individualize 65 for one patient, 75 for one patient, 85 for a third patient. So it is almost impossible. So I would end my debate with that. So thank you very much. Again, it is a beautiful quote which sort of resonates as to what we are dwelling today. Sadness is caused by intelligence. The more you understand certain things, the more you wish you didn't understand them. Thank you.
Pradeep put a lovely picture. and Pradeep himself says he's highly predictable, right? So it's predictable. And also he said on record that he has a high quality of action. He keeps high quality of action. We have all seen that, right? But to be honest, right? And a lovely book. Atul Gawande, one of the major person. He was one of the main person who rolled out the Obamacare. And in fact, we have had a wish to invite him in the conference itself, but due to the again changing scenario, he couldn't confirm that in any part. And he is a person who came up with that mostly the surgical checklist concept, which has reduced the maximum number of error-based mortality itself. So otherwise, because human error is and unsafe processes is the 5th common cause of death overall in hospital death worldwide. So this concept of checklist we came up with the checklist manifesto now. This is definitely good. But what I was trying to say, right, which actually Pradeep reflected here, is that you should have a number. So my point is, it should not be sacrosanct 65, but you should decide according to the clinical situation, according to the individual patient, your level of support that you have, your armatorium, you decide on a number and try which could be higher in elderly hypertensive patients, which could be a little lower in a normotensive young adult patient having a trauma or something like that. So it should not have to have one single number in everything. And here I agree with that. Pradeep looks very sorrow because he has read much, he is intelligent. He should have come here and drowned himself with the post-conference activities which Maharaji has actually arranged for and have some good time with us. So thank you. I think you have got the answer, right? And thanks Pradeep for a lovely presentation, and he really made me look good on that.
You being on call on Monday, Pradeep being on call on Tuesday, I don't want to be in that ICU. Your measures will go up on Monday, come down on Tuesday, go up on Wednesday.
Ganjam, I was we were coming together, me, Pandit sir and Gunjan, and all through the travel part, Gunjan will agree with me, I was giving her the gyan that we should come down, and so I really have sort of trying to excel the art where I should not be anger management issue and all others, where I should stop fighting. It doesn't help, right, in any sense of any field of life, obviously particularly marital life and professional life. Right, you are always on the losing side. So it's better to be having your own inner peace and others. So I actually do accept that part, to be honest, that we should have in a critical care. We are too much burdened with evidence. We are too much, and we changes every year, almost or every month maybe, right? And we are too much burdened. So we should have a much more common sense, sensibility, and more of a pragmatism to practice. The evidences are good, but please read through, if you are really reading, read through the article, read through the in between the lines, and learn about a little bit of the statistical, because all your decisions are based on the evidences which are based on the statistical outcomes, and we don't understand the statistics. So that sort of thing is really dangerous for us. So we should have a blend of both evidence, knowledge, as well as the experience that we gather from the patients themselves.
Coming online.
Yes, trying to be online, not to put time to waste. We will better. That is one. We will start once it comes up.
The comments, how many of you would want to target a map of 65? How many of you would want to have an individualized map? How many of you would want to have Vishwarupam like Arindam? Arindam, you seem to have tilted the argument in your favor. I think both of them are right in their own ways. Like, yes, we need to follow the guidelines. We need to be having some sort of a target, especially when you are not available to 24/7. You want to guide your juniors. At the same time, you also need to individualize patients, because you know that no two critically ill patients are the same, and the concept of organ perfusion is not only variable in an individual, but it also varies during different phases of his stay in intensive care unit.
What I observed by targeting the blood pressure in ICU, if our target goes up to 80 NAP or 85, that we feel that our target is 65, and ask them to reduce the vasopressors, reduce the noradrenaline, reduce the vasopressin, all these things. And it will come to 65, again it will go down to 50, 45. Then urine output will stop coming down. Again we will increase the noradrenaline, increase the adrenal vasopressin. Again it will go up to 80, 85. So I don't feel the 65 is the target to be reached. As Sir said, it should be individualized. Depends upon the clinical urine output and other parameters.
Just a word of caution: whenever you are targeting different maps, also keep a watch on on your own map levels. It's inversely proportional. Patient's map goes down, our map goes up.